Hi guys, Dr. Douglas Gillard here. I'm going to do something a little different today. Now I've never done this before, but let me explain first. I get a ton of email from people with back pain and neck pain, and they're asking questions, and I really cannot and I don't answer emails like that without doing it through a professional service. That's because I really need to speak with a person, I need to find out their neurological status, and then importantly I need to go over their images, their MRIs, their CTs, discography, whatever, with a fine tooth comb, which I do right with them via GoToMeeting. But this time I made an exception because this email was so sad. It really tugged at my heartstrings. And it's a it's a sad story. In my opinion, it could actually be life-threatening, as you'll see in the video. And I just really feel bad. I think he was really treated poorly, and you'll see. I don't want to spoil the video for you. But now, with his permission, I made kind of this is how I would do a coaching session, although I would have a lot more information because I can't speak his language. But so in the first part of the video, I laid out the history, some of the neurological findings, and then the key images, the key image findings. So you will get the whole story by watching this 20-minute part one. If you want to see what a coaching session's like, when I really go over images, I put part two of the video where I did that. I really went over the images and some of the dangerous surgical errors that you'll see in this part one. They really show up much better in part two when I can switch between the different cuts. So I encourage you to watch that. All right, without further ado, let's go ahead and start this. And of course, let's do a little warning here. This video is for educational purposes only. Do not take any of the information I say or anything that you glean from this video and act on it yourself without consulting your primary healthcare provider. Now that that's out of the way, let's talk about Bill. All right, so here's what I know about Bill. Well, first of all, he can't speak English or write English very well, and we've been using a Google Translator to try to piece the story. So I probably don't have everything correct, but here's the gist of it. The original injury happened, he's 31 now, it happened about 11 years ago. He was playing sports and he got hit in his back and he felt pain, and that started it. He sought medical treatment and was diagnosed with a quote crack in his L5 vertebrae. And we actually have a CT back from 2015, which we're going to show you what that crack turned out to be. He had minimal low back pain, no leg pain. He was able to resume a fairly normal life until about when he was 26 years old. So that was what? That's 5 years ago. The wheels kind of fell off the wagon. He started getting severe bilateral lower extremity pain from his butt all the way down to his feet. Also had low back pain, which wasn't that bad, but so extremity pain really made him quite disabled. He was treated by he had the proper treatment. A neurologist, psychologist even got on board, rheumatologist, physical therapist. All these treatments failed. He was on all sorts of medication. And then finally, after all conservative care failed at the age of 29, so that was, what, 2 years ago, he tried a two-level interbody fusion in his country, which is in the Middle East. It's not a little tiny country, it's a big country, so I'm disappointed with the results of this. I think they should have done better, as we'll see. Anyway, the fusion has worsened his low back pain. So it didn't really affect his leg pain. It didn't help his leg pain at all, but it didn't make it worse. If I'm understanding him, which is kind of surprising when you see where this pedicle screw is. So he's unable to communicate or I can't communicate with him real good. That's about all I can get. I do know that the EMG NCV study, I don't know when it was performed, if it was after or before the surgery, but I read a report in English that there was bilateral L4 radiculopathy. So that explains it. Radiculopathy, I mean, that test, the specificity is very high for EMG NCV. And so when the test is positive, there's no question that you have nerve damage from something. So if that was after the surgery, I then I can have an explanation. If it was before the surgery, the fusion, uh, he's probably unstable, is what I'm thinking. I don't know. I've asked him whether or not he's had a flexion extension x-ray study to see if he's stable or unstable, but we don't know that. So currently he's in moderate to severe distress, low back pain, uh, I'm sorry, currently has moderate to severe bilateral low back or lower extremity pain with significant low back pain, which is also much worse. The major complaint, though, is horrible pain in his both lower extremities. He's severely disabled. I couldn't get an oswestry to him. I couldn't find the language. But 31 years old, he's unable to sit, stand, walk for more than about 15 minutes. So he's quite disabled. He's been emailing me asking for help. So let's go over these. Let's see what's going on. So the first thing, and we'll go over these for real in a little while, but here's the key image here. So this is a study from January of 2015. It's a CT scan, and the left pedicles, as you now, if I'm going to lose you here if you haven't went over how to read your MRI video, so go over that. MRI and CT are similar. I'm not going to go over that too much, but this is a view from the side. Here's the vertebral body right here. This is your stomach here. This is your low back here. Your belt would go right through this level here. Your legs are down here. Your head would be up, way up to the top here. So this is a vertebral body. Let's look at this one. This is L4. Short pedicles. His pedicles are a little short, but here's his superior articular process. This is his pars intraarticularis. Here's his inferior articular process. The whole thing's called the articular pillar, and right in the middle of the articular pillar sits the weakest part of bone, the pars. Notice how thick this is. This is a normal looking pars. Here's another one. That's normal. Now look what's happened here at L5. So this is hypoplastic. This didn't form right during embryogenesis. So he's got a weakness here to begin with, but you can clearly see a nice black fracture line right through this. It was not on the other side though. So this is a unilateral spondylolysis, right, without slip. It has the back of the vertebral bodies of S1 and L5 are right together, so no problem there. All right, so that's what that crack in the back was all about, and that in and of itself can cause quite severe low back pain, but probably not leg pain. It might refer pain into your, I would suspect, on the right buttock and maybe into the right posterior lateral thigh, but unusual for it to go all the way down, and I can't explain why you would have bilateral leg pain. I didn't see anything on the other side, so it's interesting. The $64,000 question is, though, if we did a flexion and extension study, what would happen to this? Maybe he's unstable. So maybe this is sliding forward when he bends forward. When he bends back, maybe it slides. Remember, if it slides greater than 3.5 millimeters, if the difference of flexion and extension is 3.5 millimeters, you're unstable. And so that can be irritating both nerve roots. I suspect that's the problem, but again, I don't have a flexion extension study and I don't know if one has ever been done. Okay, let's move on here. Let's see. Oh, here I'm showing you just another cut. So this is the overhead view called the axial view. This is the lumbar spine here from the side. Here's a cut line going right through the defect. There's the pars defect again. See, here's normal. Here's the fracture line. And I wanted to show you the hypoplastic, the pars on the right side. Remember, images are always reversed because we're looking up, but they're always reversed from how we talk about them. So this is the right side. And look at the left pars, the left posterior arch here. The roof is quite thick, normal. And this is much skinnier. So this is hypoplastic. This is why it fractured in the first place. All right, and for my students, we have actually a lecture coming up on this next week. So this is a phenomenon called stress shielding. And biomechanically, remember, the spine transfers weight longitudinally down, mainly through the body, but also through the facets in the posterior arch. Since this is fractured, it doesn't take its share of the load, and therefore the left side is overloaded. And as you can see in this image, it is quite sclerotic. So it's developed, osteoblasts have responded to the stress. That's called Wolff's Law. It's well in effect here, and it's laid down more bone, and it's actually getting thicker. So that's called reactive sclerosis, a classic sign of a unilateral spondylolysis. Now we have the fusion. So this is about 2.5 years ago. So they got the idea that this must be unstable and they're going to fuse it. Strangely enough, they did an old school posterior fusion where it looks like they didn't, and we'll go over this on the images, they didn't roto-root out the facet joints. They didn't put a cage in. This is not an inner body fusion. And they were supposed to pack bone back here. They did this at L4, L5, and L5S1, so there should be a whole bunch of bone. They tried to kind of make the L4, 5, and S1 segments into one unit. And they do that by, if you will, pouring cement back here and letting the cement harden. Of course, it's not cement. They probably used cadaver bone and ground it up into a paste. I doubt if they used BMP or anything. I don't think they did autologous bone either from his hip, which probably would help this. But we'll see in the slide. There's no evidence of any type of fusion here at all. But the reason, and part of the reason I'm making this video is I couldn't make him understand what I'm so worried about. These are pedicle screws. This is the anterior part of the vertebral body. Here's your belly button would be, up here further. This is your back. Okay, this is your right side. This is your left side. These pedicle screws, you can see the shadow of them. They go through the pedicle, or in this case, the ala of the sacrum in the sacrum. But this is going through the L5 pedicle. There's absolutely no reason that they should have extended these pedicle screws into the soft tissue. These pedicle screws should not. In fact, they should go into the vertebral bodies themselves. There are some blood vessels. Uh, there's all the iliac vessels, internal iliac artery, internal iliac vein, external iliac artery, external iliac vein. And in fact, the thing that shocked me, this is the internal iliac vein right here, this circle. And they got the pedicle screw not only touching it, it's actually looks to me like it's indenting the internal iliac vein. That is dangerous. It's not as dangerous as an artery, which is more pulsatile. But over time, there's a chance this could rupture. If this ruptures, you bleed to death. Very few people actually make it to the hospital when these things rupture. They're under pretty good pressure. So this is ridiculous. This should not be. And I tried to explain to him, but he didn't understand. These pedicle screws should be removed, especially this one right here, because there's a chance this could endanger his life, in my opinion. So not good. You'll see it when we go. And I did some Photoshop here, and I highlighted in the internal iliac vein. And you can see that's just a really bad situation. The other one's over here. Doesn't look like it's compressing, although these are metal artifacts here, so we can't see. But this is just really sloppy work, in my opinion, and it could endanger this patient's life. All right, so maybe someone, if he starts talking on the thread, maybe someone can explain that, because he didn't understand, and the translator couldn't. I guess it just didn't translate right. Okay, so I'm worried about that. So here is another cut. This is L5. Here's the exiting. There's the S1 roots right here. But this is supposed to be a fusion, right? This should be filled with white bone, right? There's nothing here. This is soft tissue. There's nothing. There's no fusion. The fusion completely failed. And here's the facet joints are wide open. So they should. Well, I guess they don't in this old school fusion. I guess they just rough up the outside of the articular processes here. But these facet joints are still moving and probably generating pain. And do you think the fracture has healed after? If it was a good solid fusion, there would be no fracture there anymore. So here's a cut through the L5 vertebral body. There it is. Still, you guys can see that. You don't have to, be a doctor to see that, I don't think. There's a little bit of bone formation there, but there's clearly still a fracture in the that would be the right pars. So this could probably still be generating his low back pain. And now, as if things weren't bad enough, let's go up to look at L4. So here's the pedicle screws going through L4. Now the surgeon did a good job on the left here. Uh, and you'll see when we go to the real images, the pedicle screw goes right through the pedicle and it stops where it's supposed to stop in the vertebral body. It's not stabbing anything out here. This is how the other one should have looked. But look at this one. I mean, really? I mean, how could someone? I don't understand what happened in there. He completely missed the pedicle. Not only that, he completely missed the whole vertebral body. I've been doing this a long time. I've never seen anything like this before. Why this has been left in there for 2.5 years, I have no idea. But now, as you know, if you've been to my anatomy page and know an MRI, you have traversing nerve roots, L5 traversing nerve roots, which we can't see. We would need this to be a contrast or an MRI, but the traversing roots are L5 are here. The exiting roots would be coming out a little bit below this, the 4 roots. But I don't talk about this very much because there's no need to. No surgeons that I've ever seen, well, I guess I've seen a couple cases online, but I've never had one before. But sometimes if you, well, how am I going to say this? The L3 nerve roots from above this segment, they actually come out, they hang out in this region, and the closer you get to the IVFs, they're right in this region. This screw is right exactly where the exited L3 nerve root, not the L5, not the L4, but the L3 nerve root. So his right L3 nerve root is undoubtedly being pushed completely out of the way by this pedicle screw. That's a source of chronic irritation. So that would definitely explain pain on the anterior part of his right thigh and his butt. It might even extend down. Probably wouldn't pass the knee if it's L3. It's usually on the front of the thigh. But so I mean, that needs to come out. If I could wave my magic wand and do anything I wanted with him, I would send him either to my two favorite, and I have no financial, or I don't even know these people, but based on my coaching, there's two clinics I like a lot. I like Hospital for Special Surgeries in New York, New York. So I would advise him to go there. I also, on my side of the country, UCSF is really good. I've had really good results with them. Stanford's pretty good as well. But maybe closer to him, I think Germany. Anybody in Germany could probably take care of him and get this fixed up and at least get things decompressed. So that would be my recommendation to him. He definitely needs to get a second opinion away from the surgeon who did this, away from that institute. Because as I said before, I think the nerve root's getting shish kebab there and irritated. But perhaps more importantly, I think this is way too close. I mean, it's touching. This shows it. It's touching uh, the internal iliac vein, and that can be dangerous. This screw needs to be taken out, in my opinion. All right, is that it? Because we're going to get to the images here. Oh, and here, for the first time, so this is this is the front, this is the back, right? So this old posterior style fusion is where they rough up the roof here, the posterior arch, the posterior part of the posterior arch, and they lay bone chips down. They're probably cadaver bone chips. And they keep their fingers crossed, but they lay these all the way down, right, to form a cast, a bony cement. No, it's really not cement, but I mean the analogy is cement. They're trying to weld all this stuff together. And at least I can see an attempt at fusion here, but it still failed. You can see huge black gaps between the fusion. It completely failed. So the only thing holding these pedicle screws are the only thing kind of holding his quote fusion together. Pedicle screws are not designed to be the fusion. They're like putting a cast around the segments, and we have that, which will give this bone time to ossify and turn hard like cement. They're not designed to to support to restrict the movement. So how long before these screws break? I don't know. They look like they're titanium because they're not giving off much of a shadow. Titanium screws are pretty darn strong, but it's probably only a matter of time for these screws break because the fusion has failed. Okay, I think no, I got an MRI here too. So if all that's not bad enough, now he's got bilateral leg pain. And this is okay, this is an MRI, right? Here's the lumbar, the vertebrae here. And look at how small this vertebral body is at 4, by the way. It's hypoplastic. And look at how big the discs are. I know a surgeon used to call this floppy disc. Uh, I call it fat disc syndrome. Other surgeon I know calls it that. No research on this, but people who have these huge discs, the disc should not be more than 1/3 of the height of the vertebral body. That's way too big. So therefore, these discs slosh and move around during movement a lot more than a normal person. And so they don't do good with conservative care with regard to back pain. They're not going to slip and slide around enough to cause leg pain, though. At L3, now this is above the fusion. And we can, by the way, it's not an interbody fusion either, right? Because there's the disc. These discs have not been taken out at all, just old school posterior fusion. But you can follow here's the cauda equina, the thecal, which is inside the thecal sac. These are all the traversing nerve roots, and they're waiting their turn to bud out of the thecal sac and go out the intervertebral foramen. But you can see we have a little weirdness right here. There's a little kind of disruption of this nice flow of the horse's tail. And if you measure this, this is not 20 milliliters. It should be 20 millimeters from here. None of this is 20 millimeters. So he's got short pedicles. He's got a congenitally narrow canal, which is okay, but there's not a lot of wiggle room here. If we put a cut right through here, if we put him in a bologna slicer and slice this up and pull this L3 slice out and throw it on the table and look at it, here's what we get. There's the nucleus pulposus of a 31-year-old. Looks really nice. The disc might be bulging a little bit. It's closed the intervertebral foramen down. I don't see any frank herniation, though. I think he mentioned in one of his emails the doctor said he had a herniation. There's no herniation here, for sure. There's that smooth bulging of the disc, and that's a little volume averaging. This is an old school MRI, not very powerful. But there's no herniation, just a little bulging. There is, however, see that little white thing right there, that little bubble? That's called an HIZ sign. I would prefer it to be a little bit whiter, but maybe it's healing. But that's an indication that he may have a rip inside this disc. So perhaps the disc is torn. Maybe we can hallucinate a rip in right here. You can't see these very good. You need discography to confirm that. But he might have an annular tear going on here, which could cause low back pain, and that would not be surprising. As everybody knows, the domino effect, adjacent segment disease is the real word for it. I think the lay people know it as the domino effect. When you fuse the two vertebrae, the one above and the one below, but there's none below in this case. But the vertebrae above the fusion takes on extra duty with regard to handling the weight of the body and twisting and turning, and it can wear the disc out. So he does have a little adjacent segment disease here. The disc is still pretty well hydrated, so it'd be interesting to see this MRI in another couple of years. This whole disc could probably be black in color from this tear. But that's not going to cause the bilateral leg pain. Now, if you measure this is the thecal sac, definitely is stenotic. It should never be less than 10 millimeters. I measured it. It was 7.96 if I remember millimeters. So he's definitely has I'll call it moderate to severe central canal stenosis. That in and of itself, however, I doubt seriously if that's enough to cause the bilateral leg pain. It's got to be at least 2 levels. I prefer 3 levels. Then you can start getting some symptoms from that. I seriously doubt that this is the cause. The EMG, I'm betting anything that EMG was done after the surgery. Although the surgeon didn't go in there to manipulate I'm kind of thinking out loud here. The surgeon didn't go in. If it was a posterior fusion, he didn't kind of crack the epidural space, so he couldn't have manipulated the nerve roots. So I'm a little mystified about why he has pain on the left leg. The right leg I can certainly explain, but the left I can't. And perhaps that's why they sent him to a psychologist to make sure his mind was clear. He's been on all sorts of Neurontin, gabapentin, Lyrica, the new generation of gabapentin. So he's been on the right medication. So I'm not 100% sure what's going on with the left leg. I can't explain it. I can explain the low back pain, but I can't explain the left leg pain, at least with the images I have. Now, the $64,000 question: what does the spine look like on flexion and extension imaging? Now, if one of these is slipping and sliding all over the place, then I can explain the bilateral leg pain. So the biggest thing is for him to get that screw out of that iliac artery. The next biggest thing is to get a simple flexion extension radiograph, and that will show whether or not he's stable. When he bends forward and then he bends backwards, these bones better not be slip sliding around on each other. If they are, it better not be more than 3.5 millimeters, or else that's thought to be enough slip to irritate both or to irritate the exiting nerve root and cause pain, as well as the traversing nerve root. All right, so that ends this section. Let's go over his real MRI images right now.